I would like to invite our next speaker, Chief RP Center, Professor Padma Shri, Dr. J.S. TITIYAL, and he needs no introduction. Over to you, sir. He will be speaking on the role of interoperative OCT for phenomenal change in anterior segment surgery.
Thank you, Arvind, for a kind invitation. And as we seen that innovation can change the life of a surgeon and improve the patient outcome. And my talk is not innovation; it is the utilization of innovated system for our better understanding, especially in the surgical area also. And I hope that this type of imaging which we can do intraoperatively will help Dr. Prasanna also to build up the surgical modules for the future also. And let me take you through the same story which Prasanna Venkatesh talked about. If you see things, you can do better. And microscope gives you just a two-dimensional image. And IOCT will give you on a three-dimensional image where you can see a cross-sectional image to see what is happening to your each step of surgery. So this is help in a diagnosis like anterior segment OCT. It will give you a new surgical planning, and you can also monitor the case on the table also. So you do incision in the cornea. You can't see what incision you have done in the microscope, but if you have IOCT, you can see I have done a three-planar incision in a femtosecond laser. So that is available on a microscope where you don't have to really have something a handheld device also. So these new IOCT microscope will give you an in vivo optical biopsy of a tissue. You can see entire length. The entire OCT can be, you can see retinal surgery, you can see the entire OCT of retina, and that is how it's going to change the concept. The same thing comes true for anterior segment surgery also. This microscope IOCT attachment are built for a retina surgery to begin with. And we have utilized anterior segment surgery because we do more anterior segment surgery than the vitreoretinal surgery. So this has a better planning for application to all sort of anterior segments, right from a collagen cross-linking to a cataract surgery, refractive surgery, all type of corneal surgery also. And this is a review article we published few years back in IGO. People can read that and gives you insight how IOCT will help you. This is the first publication of IOCT in knowing the ICL position inside the eye and the real-time bolt of ICL. First publication in literature where we could assess the ICL on the table and realize what is a bolt. And these IOCT microscopes don't have a micro caliber meter. So we devised a way to how to measure them and calculate the magnification, the magnification factor, and actually we could measure the bolt on the table, and we analyzed them post-operatively with the anterior segment OCT. It was beautifully matching. Now this calibrated caliper is now used for all corneal surgeries for other aspects also. Like in keratoplasty, it can be used for all the studies being done where they found that if you use IOCT, it will change your surgical planning in almost 40% of your cases, which is true for all the steps of surgery, right? From the, if you're doing a DLK or dark procedures, right from the initial depth to needle insertion to a bubble formation can be seen beautifully in these cases. This is a diagrammatic representation. When you do a initial debulking, you can see this is a thickness. We have done a debulking here, which is around 40%. Then injected the air. You can see the descending membrane going backwards. And you can see a descending membrane here getting detached. As it will make a nick in the stroma, the descending membrane will come back to the stromal area. And this is the end of surgery. You can see the clear descemetes also. So this type of visualization was not possible on the table, and most of the time you will make more complication and these difficult surgery also. In endocellular keratoplasty, it is also very, very helpful in making the thickness measurement, choosing the keratome head to create the desect lenticule. Subsequently, during surgery, you'll know what has happened to your desect graft inside the eye. This is the first publication using the IOCT to see how effectively your donor lenticule gets attached to the stromal bed. People had a blind appreciation, keeping the pressure high for 10 minutes, 12 minutes, 15 minutes, thinking the graft would have been attached, and next day morning they see graft is detached. So this is the actually seeing on time on the table where you use the IOCT to see this is what the graft looks like and this is the graft is attached. We made a comparative study where we injected air for 3 minutes, 5 minutes, 8 minutes and massage. We realized the graft gets attached within a minute or so if you do a bimanual procedure. And this we could see on the table first time, and you can manage the case appropriately. The IOCT really gives a biopsy of entire tissue, and you can see the interface, the lenticule, everything can be picked up very nicely. In fact, you can orient the graft, orientation graft can also be seen. This is the DSEC lenticule inside, this is the endothelial side, this is the stromal side. If you punch from endothelial side will be bigger. And this is the correct orientation. You can say we call it acute angle bevel sign for a DSEC to really comprehend the position also. So these IOCT microscope we are used in a DMEC procedure also to see the orientation of a DMEC roll inside the eye. This is the incorrect and this is the correct orientation of DMEC roll inside, and you can pick up on the microscope. If this is the picture, you can see what is the DMEC roll, and ultimately you can attach them appropriately. So this is the beauty of this system. It gives you visibility on the table and you can correct. If you have an incorrect orientation, then you can recorrect it and attach in appropriate manner. You can see through the hazy corneas also and do a good surgery in these cases also. So these are innovations in terms of seeing better and doing better in these cases. In cataract surgery, it really helped. I think Dr. Rajendra Prasad showed a beautiful technique of a white cataract. This is our innovation in terms of classifying the white cataracts. As Madam asked the question, we could classify on the table. Like you can see these cataract by your slit lamp examination with your anterior segment OCT morphology. But what happens when you puncture? What happens, that is not known, and that is only can be seen by IOCT picturization. So we could classify these white cataracts in multiple spectrum. Of we classify in 4, but you can have an between these grades various spectrum of white cataracts. So see these cataracts and you can manage case appropriately. This is the type 1 variety where you have a very less convexity and very smooth homogeneous ground glass appearance OCT. There is no fluid in this. As you make a puncture, no fluid comes out. You have a nice configuration. You can do a capsular rhexis very comfortably in these cases. This is type 2. We can see here you have a little convexity. You have a sheets of a hydrated cortex can be visualized going from one area extent to other extent, and you can see thick. And all these clefts are beneath that hydrated cortex. You can imagine in this case what will happen as soon as you make a nick, no fluid comes out because this cortical fiber prevents fluid to come out. Pressure still remains there. And see this mountain coming out of a hydrated cortex. And this is the case, peripheral extension is going to happen unless you make a small opening in these cases and manage this case. So this case I can understand it will not be amenable to needle aspiration because it is a thick cortex here. So this case requires the aspiration of cortex, not the aspiration of fluid. That you have to understand. So this is another case, type 3, where you have a combination. You have a sheets which are broken and you have multiple pockets. So this is the case where you have a raised lenticular pressure. You can aspirate with a needle. You can do a micro puncture, macro puncture. Aspiration will take out the fluid, and you can see I made a little puncture of milky, not milky fluid. It's the liquid, which is like a oily. Like there's a stages of fluid also. This is the oily fluid will come out and decrease the pressure. Convexity becomes concavity. I can do an access subsequently very appropriately. I'll just skip the thing. This is type 4, which you talked about, madam, a total fluid. You can see the convexity and entire area is homogeneous, but this is fluid. The fibers are down below. So as soon as you make a nick, the fluid comes out. Now pressure releases, you can do a nice capsular access. Here also needle aspiration will help in this case. So this is how you can titrate your white cataract and manage your cases appropriately. Other area we worked on the posterior polar cataract. You can classify them according to visibility of a posterior capsule, integrity, and the disc diameter size also in these cases. Accordingly, you can understand what will happen. This is type 3, where you have a large disc, hard nucleus. This is called, a moth-eaten appearance. You can't see the posterior capsule at all. So this is a case, the rupture may be quite, may happen in these cases. This is the picture you used to see the section of the posterior polar cataract. But if you do a hydro, you're not sure how much hydro you have done. This is the image you'll see here. This is the endonucleus. This is the fluid. This is the epicortical cushion. So you can titrate what is happening. At this stage, you can see the posterior capsule also and manage your case accordingly. So that's the beauty of a section of the tissue during your surgery and the implication of each step of your surgery during this surgery also. We have used this IOCT in a refractive surgery also, smile procedure. You know the lenticle position, you have a dissection position can be understand, and use for effective dissection anteriorly, posteriorly, and take out the lenticule in these cases also. You can understand there are difficult situations in pediatric cataract. Examination is so difficult. Patient normally seen under microscope, and microscope doesn't give you a 3D pixelization. IOCT give you all the pictures, and you can do the nice assessment and plan your surgery accordingly. So I can summarize, it has an application in all sorts of anterior segment surgery. Not only in a cornea cataract, it has application in a pterygium surgery, ocular surface, squint surgery, every surgery, glaucoma surgery, people are using IOCT now. And I can understand this is going to be a future tool for a microscope to have OCT attachment for every microscope. Thank you and kind.